Transmyocardial revascularization uses a laser to create channels in the wall of the left ventricle in the ischemic areas. These channels may deliver oxygenated blood directly from the ventricle to the ischemic defect. Laser energy creating the channels also stimulates angiogenesis. Lased myocardium typically displays increased vascularization in the area immediately surrounding the lased channels. The injection of growth factors or genes can enhance the result. Most TMR patients report immediate improvement in anginal symptoms. The magnitude of improvement in angina averages nearly 2 classes, and many patients experience a total elimination of symptoms. Cardiodyne's TMR system offers a unique solution to the problems of the ischemic myocardium. It includes 4 components. First, Cardiodyne's proprietary SuperPulse holmium YAG laser offers 80 watts, the highest power of any holmium laser available for use in TMR. Second, Cardiodyne's proprietary auto-fire system creates each channel within a single heartbeat during diastole. At that time, the heart chamber is full of blood, the wall is its thinnest, and the electrical activity of the heart is minimal. Synchronization with diastole reduces the chance of initiating arrhythmia. The laser energy is delivered by Cardiodyne's proprietary channel maker fiber optic delivery system. This device enables the procedure to be performed during open heart surgery. In a minimally invasive thoracoscopic procedure through a trocar puncture between the ribs, or percutaneously. The fourth component is the AccuJect injection system for automatically delivering angiogenic growth factors or genes near the end of the channel-making process. Unlike other TMR lasers, Cardiodyne's system creates the channels in 3 phases. The first phase involves advancing the double bevel needle, which encases the fiber optic approximately 1/3 of the way through the heart wall in 50 milliseconds. No lasing occurs during this phase, leaving only a needle puncture in the epicardium. During the second phase, the laser fires while the fiber needle is advanced through the balance of the heart wall and into the chamber. Then withdraws to the original laser firing position, all in 300 to 400 milliseconds. In the third phase, the laser is turned off. Angiogenic agents are injected into the completed channel, and the fiber needle is then withdrawn from the heart wall into the cannula within 50 milliseconds. This completes the channel-making process. When the channel maker fiber is withdrawn from the heart, it leaves only a needle puncture in the epicardium, and bleeding from the heart surface is minimal. Note the absence of bleeding from the earlier channels. Cardiodyne's holmium laser creates the channel through the endocardium between heartbeats. The SuperPulse laser produces 31 joules of energy in 10 pulses of 3.07 joules each over a period of 400 milliseconds. An amount of energy comparable to that of the 1,000-watt CO2 laser. Now, let's examine how the auto-fire system eliminates the guesswork involved with channel creation on a beating heart. Prior to the procedure, the physician enters the patient's identification number and selects either an epicardial or endocardial approach. The physician may choose one of 3 procedures under epicardial and 2 under endocardial. In the example we present here, the physician chooses epicardial, beating heart, with ECG synchronization. Once this screen appears, the physician enters the patient's heart wall thickness, which has been earlier estimated by ultrasound, the desired distance into the chamber the fiber needle is to travel to assure the channel is complete, and the desired distance into and out of the epicardium the fiber needle will travel without lasing. Once these measurements have been programmed into the auto-fire, the physician touches the ECG display, and the synchronization complex is overlaid on the patient's ECG tracing. The physician can now program the time intervals to complete the procedures during diastole. T1 is the time from the peak of the R wave and the leading edge of the synchronization complex. The white left marker can be moved up to the trailing edge of the T wave. The right white marker can be moved up to the leading edge of the P wave. The white bar indicates the lasing period. The 2 small blue bars at each end of the white bar indicate the time periods when, without lasing, the fiber needle enters and exits the epicardium. Also displayed are the total channel making time, the number of joules of energy per channel, and the number of channels made. The channel-making parameters of up to 80 channels for 5 patients are stored in the autofire's memory and may be downloaded for patient record purposes. Once this information has been entered, the surgeon simply positions the tip of the channel maker catheter on the heart surface. When the physician presses the button on the handpiece, a channel is automatically created between heartbeats. If an epicardial procedure on an arrested heart is chosen, the same 3-step process automatically occurs when the surgeon presses the button. If a percutaneous endocardial approach with ECG synchronization is chosen, Cardiodyne's 8 French directable percutaneous channel maker catheter is advanced through a standard guiding catheter into the left ventricle. The radio-opaque tip of the channel maker catheter can be articulated up to 180 degrees by turning the collar on the handpiece. The cardiologist inputs the heart wall thickness and the desired depth of the channel into the heart wall. With the autofire system, perforation is physically impossible. Since an endocardial channel can be made comfortably in less than 400 milliseconds, the left white marker need not be as close to the T wave, and the right white marker can be moved away from the P wave. When the parameters are set, the channel-making process can begin. When the handpiece button is depressed, the channel is automatically made, and if desired, angiogenic factors or genes can be injected. The autofire system allows the cardiologist to concentrate on positioning the catheter in the left ventricle. This eliminates the need to manually activate the laser, advance the fiber, deactivate the laser, or inject angiogenic agents. The physician may use the AccuJect injector in combination with TMR or in a standalone injection procedure from either the epicardial or endocardial surface. The AccuJect delivers 25 shots of 1/10 cc each and automatically refills itself when empty, so the procedure need not be interrupted. Cardiodyne's unique TMR laser and injection system offers the highest power laser compatible with fiber optic delivery, ECG synchronization, delivery of angiogenic agents, and automated channel creation. It reduces procedure time by creating each channel during a single heartbeat. It minimizes bleeding at the heart surface by starting the channel several millimeters below the epicardial surface. And it reduces the risk of arrhythmia by creating each channel during diastole. Transmyocardial laser revascularization and angiogenic injection promise to alter the future treatment of coronary artery disease. With its unique TMR and injection system, Cardiodyne will lead the way into that future.